Good afternoon, dear students. Today we'll discuss such an important question like low-grade fever and fever syndrome in the practice of the district general practitioner. Every person suffers from a disease that is accompanied by fever at least once a year. According to statistics, the body temperature increase is alone or in combination with other symptoms the most common reason for making a clinical appointment or arranging the doctor's home visit. What is normally done in this case is the determination of fever origin and, if necessary, prescription of an adequate treatment. Fever is a rise in body temperature to above 38 degrees Celsius as a result of exposure to pyrogenic irritants accompanied by the increase of body systems activity. And of course, you should remember that not every increase in body temperature is a fever. So, fever is the thermoregulatory increase in body temperature, which is an organized and coordinated response of the body to disease. So the body raises its temperature itself. Main mechanisms of fever. The immediate cause of the fever is the presence of pyrogens. They can enter the body from the outside, exogenous, in case of infectious and non-infectious diseases, or formed inside, endogenous, cell tissue. All pyrogenic substances are biologically active. Under the influence of the primary pyrogen, the body forms the secondary pyrogens, cytokines, interleukin-1, interleukin-6, tumor necrosis factor, alpha interferon. They are produced by neutrophils, monocytes, macrophages, as well as various malignant tumors. The appearance of body temperature due to the influence of endogenous pyrogen on the thermoregulatory center located in the anterior hypothalamus. There are 6 types of fever depending on the daily fluctuations in body temperature. First type is permanent, daily fluctuations of less than 1 degree Celsius and characteristic of typhoid, fever, salmonellosis, brucellosis, and pneumonia. So this type of fever, permanent fever, without large daily fluctuations, high daily fluctuations, is very typical for typhoid fever, salmonellosis, yersiniosis, and pneumonia. The second type is remitting. Patients with daily fluctuations of temperature from 1 to 2 degrees Celsius, but the body temperature does not reach the normal temperature. Typical for purulent diseases, pneumonia and tuberculosis. The third type of fever is intermittent, when periods of temperature increase correctly alternated with periods of the normal temperature, typical for malaria. Fourth type, depleted or hectic, with daily fluctuations from 2 to 4 degrees, sometimes to 5 degrees Celsius, and accompanied by debilitating. It occurs in severe tuberculosis, very specific for sepsis and septic diseases. Fifth type, or reverse type, perverted type, when the body temperature in the morning is higher than in the evening, observed in tuberculosis and septic conditions. And the last type is improper, random various daily fluctuations in temperature curve without any regularity. It occurs in many diseases such as influenza, pleurisy, and others. Low-grade fever. Low-grade fever is increase in body temperature up to 38 degrees Celsius. Under chronic low-grade fever, we understand wanton fever lasting more than 3 weeks, which is often the only complaint of a patient. So long low-grade fever. Temperature between 37 and 38 degrees Celsius. The duration of this fever more than 3 weeks. Lack of deviations with careful survey. Lack of body weight deficit. The dissociation between heart rate and degree of temperature increase. And negative paracetamol test. There are 2 large groups of patients with long low-grade fever. First group includes patients without inflammatory changes in common blood count, and second group include patients with inflammatory changes in blood. So the first group, no inflammatory changes in blood. It could be urocirculatory dystonia, premenstrual syndrome, thyrotoxicosis, post-infarctual thermoneurosis, hypothalamic violation syndrome thermoregulation, iron deficiency anemia, peptic ulcer, and bronchial asthma. And of course, artificial fever in patients with simulation or aggravation. The second group of patients, group with inflammatory changes in blood. Etiology factors or diseases. Of course, it could be asymptomatic lesions of chronic infections, some forms of tuberculosis, rare specific infection, immune inflammation, and paraneoplastic reaction. What inflammatory changes do we mean? We mean elevation level of ESR, C-reactive protein, presence of dysproteinemia, high level of fibrinogen, and elevation of circulating immune complexes, presence of rheumatoid factor, and immunoglobulins. There are 5 steps for diagnosis patients with low-grade fever. First step, proof of authenticity subfebrile. Step 2, minimum examination. Step 3, exclusion of violations hypothalamus. Step 4, the exclusion of inflammatory diseases. Step 5, the exclusion of cancer pathology. So the first stage proof of authenticity of low-grade fever. Recommended temperature measurements every 2 hours over 1-2 weeks, excluding nighttime. There are 3 points for temperature measurements in both armpits and per rectum. It is normal that the rectal measurement is 0.5 degrees higher than in both armpits. And of course, we should keep it in our mind cases of suspected simulation. If we suspect an artificial fever, we should measure temperature in the presence of medical staff, simultaneously measure oral and rectal temperature, determine the temperature curve and pulse rate, make careful inspection of the skin to identify possible infiltrates, traces of injections. Second and third stage, or second and third steps: history collection and minimum survey. A thorough survey examination, complete body count, urine analysis, X-ray examination, and ultrasound. It's a minimum survey for every patient. Of course, especially we should differentiate diseases without inflammatory changes in the blood. If we suspect the encephalic nature, of course, we'll need consultation of neurologist and endocrinologist. Another symptoms of neurocirculatory dystonia could be labile blood pressure, abnormal heart rate, emotional unsteadiness, and sweating. Also, low-grade fever could be a symptom of premenstrual syndrome, 7-10 days before menstruation. Thyrotoxicosis symptoms. You should remember, of course, eye symptoms, presence of tachycardia, irritability, tremor of the fingers, and loss of weight. Fourth stage: targeted search, chronic infection and inflammation. This stage includes laboratory tests, specialist consultations like gynecologists, dentists, otorhinolaryngologists, and physiatrician. You may prescribe investigations like cholecystography, respiratory function test. You should repeat urine culture test, Neutropenic test. You need a consultation of a doctor of infectious diseases, consultation of the neurologist to prescribe echocardiography, and of course you should exclude connective tissue diseases like rheumatoid arthritis, vasculitis, and ankylosing spondylitis. And the last stage, you should exclude or confirm the cancer pathology. So you'll need a fluoroscopic and endoscopic gastrointestinal research methods, radioisotope methods for liver, bone, and kidney, thyroid ultrasound investigation, intravenous urography, and CT scan. Fever of unknown origin. The term fever of unknown origin represents the condition which is frequently encountered in clinical situations and in which the fever is the main or sole symptom of various diseases which diagnosis is unclear after the usual and, in some cases, further investigation. Definition of fever of unknown origin. Temperature greater than 38.3 degrees Celsius or higher than 109 degrees Fahrenheit on several occasions. Duration of fever greater than 3 weeks. And of course, the main criteria: failure to reach diagnosis after 1 week in hospital. And of course, the main etiology factor of fever of unknown origin is a common disease with unusual cause. So let's bear it in our mind. Differences between low-grade fever and fever of unknown origin. Low-grade fever: unwarranted increase from body temperature from 37 to 38 degrees Celsius, lasting for more than 3 weeks, usually the years, and is often the only complaints of patients. And fever of unknown origin: increase in temperature above 38.3 degrees Celsius for more than 3 weeks. Wherein the diagnosis is uncertain after 3 outpatient visits or 3 days hospital survey. So, of course, you understand that fever of unknown origin is a syndrome. Thus, a kind of a syndrome was isolated, which differs from other cases of fever. Based on this criteria, fever of unknown origin should not include cases of so-called low-grade fever of obscure nature, often wrongly referred to as fever of unknown origin. There are 4 main categories of fever of unknown origin. The first category is classic fever of unknown origin. This category is typical for patients with temperature more than 38.3 degrees Celsius, with duration more than 3 weeks and evaluation of more than 3 visits or 3 days in hospital. This category, classic fever of unknown origin, is extremely typical for malignancies, infections, and non-infectious inflammatory diseases. The second category is nosocomial. You can find this category in patients with temperature also more than 38.3 degrees Celsius, in hospitalized patients more than 24 hours, without fever or incubating on admission, and of course evaluation of at least 3 days. You should suspect in these patients healthcare associated infections, postoperative complications, and also drug fever. The third category is neutropenic fever in patients with immune deficient. Also is very typical elevation of temperature more than 38.3 degrees Celsius, absolute neutrophil count less than 500 per cubic millimeter, and also evaluation of at least 3 days. You should exclude majority infections and viral infections, bacterial and fungal and viral infections. And the last group is HIV associated in patients also the same, with temperature higher than 38.3 degrees Celsius, duration of more than 4 weeks for outpatients and more than 3 days for inpatients. And of course, you need a confirmation of HIV infection. The reason of fever in this category, it could be HIV infection, like a primary infection, and of course secondary infections with mycobacteria, cytomegalovirus, toxoplasma, cryptococcus. Also, you should exclude lymphoma and immune reconstitution inflammatory syndrome. Fever of unknown origin may be the reason for generalized or local infectious inflammation in 30 to 50% of all cases. The second reason is tumor. So tumor diseases, about 20 to 30%. Systemic connective tissue disorders like rheumatoid arthritis, systemic lupus erythematosus, systemic vasculitis, Still's syndrome in adults, about 20%. Other diseases, a variety of etiologies, pathogenesis, diagnosis, treatment, and prognosis, 10 to 20%. And approximately in 10% of patients, the cause of fever cannot be established, despite a thorough examination with the use of modern techniques. On this picture, you can find a list of the diseases that are most frequently encountered. Of course, it could be tuberculosis, malignancies, hemoblastosis, pockets of bacterial and parasitic infections that are hidden in the abdominal cavity, infectious endocarditis, and diffuse diseases of connective tissue. Let's talk about classic fever of unknown origin. Let's repeat the main etiology factors, the leading causes of this fever. Of course, it's infectious diseases. It could be unrecognized abscesses, abdominal or perinephric, and also it could be infectious endocarditis. Of course, you should keep it in your mind that presence of HACI group or HACIC organisms is very important, like etiology factor of fever of unknown origin in patients with classic form. And this group usually able to be cultured with modern techniques. Difficult to culture organisms like Bartonella, Aspergillus, Coxiella, and Brucella. Of course, tuberculosis, histoplasmosis, and osteomyelitis. On this slide, you can find X-ray of patient with disseminated tuberculosis of both lungs. On these and next pictures, it's a CT scan of patient with abscesses of abdominal cavity. And osteomyelitis. There are many rheumatological diseases that may cause presence of fever of unknown origin. Of course, it's Still's disease in adults. You can find in patients during examination presence of fever, or rash, arthritis, sometimes tonsillitis, myocarditis and pericarditis, rheumatoid arthritis, SLE, systemic lupus erythematosus, temporal arteritis or Heart-Tone disease or Heart-Tone syndrome, Heart-Tone vasculitis in patients older than 50 years with headache, anamnesis, and symptoms of polymyalgia, and of course presence of high level of ESR, and of course polymyalgia rheumatica. So besides rheumatological disorders, of course you should exclude different malignancies. Common malignancies associated with fever of unknown origin. It is lymphoma, leukemia. I should say that hemoblastosis are the most important cause from all malignancies for patients with classic fever of unknown origin. Tumors metastatic to the liver and renal cell carcinoma. Presence of this syndrome of fever of unknown origin in patients with malignancies most likely associated with presence of pyrogenic cytokines, necrotic process in tumors, or infection also could be reasons of elevation of body temperature. Another causes of fever of unknown origin. Of course, you should remember about self-induced fever, drug fever, because of taking some medicines such as antibiotics, antihistamines, and non-steroidal anti-inflammatory drugs. Familial fever syndromes. There are many familial fever syndromes with genetic predisposition. The most common is familial Mediterranean fever. Besides this fever, of course, you should remember about TNF receptor associated periodic syndrome and hyper-IgD syndrome. Of course, hemophagocytic syndrome, inflammatory bowel disease, pheochromocytoma, pulmonary embolism. About 6% of all patients with classic fever of unknown origins are patients with pulmonary embolism, thrombotic thrombocytopenic purpura, and thyroiditis. And of course, you should confirm absence of chronic infection, tonsillogenic, odontogenic in the nasopharynx, orogenital, gallbladder, bronchogenic, and you should exclude presence of infective endocarditis. Tuberculosis, the most important disease, the most important cause for patients with fever of unknown origin from all infectious diseases. Tuberculosis is the most popular infectious disease and the main infectious disease which may lead to fever of unknown origin. Where could you find tuberculosis process in the body in patients with fever of unknown origin? It could be mesenteric lymph nodes, bronchopulmonary lymph nodes, and sometimes even extrapulmonary in bones or urogenital. Rare specific infections: brucellosis, toxoplasmosis, infectious mononucleosis, Epstein-Barr virus, HIV infection, and syphilis. Nosocomial fever of unknown origin, the second category of all fevers of unknown origin, typical for patients who were hospitalized more than 24 hours and they didn't have any signs of inflammation or infection or incubation on admission. Etiologies include drug fever, nosocomial infections, postoperative complications, and central fever in patients with stroke. The third group, immune deficient fever of unknown origin. Patients with significantly impaired immune response often don't have traditional signs of inflammation, and this makes detection of infection more difficult. Neutropenic fever of unknown origin. Neutropenia is amount of neutrophils less than 500 per cubic millimeter, decreased mucosal defense, and febrile neutropenic patients receive empirical courses of broad-spectrum antibiotics and often antifungal agents. Causes of fever in patients with prolonged neutropenia who are receiving broad-spectrum antibiotics. The most common reason of this type of fever is fungal infection, more often susceptible to empirical therapy and only 5% resistant to empirical antifungal therapy. Of course, it could be bacterial infection and also graft versus host disease after hematopoietic stem cell transplantation. Very rare viral infections: cytomegalovirus, Epstein-Barr virus, and varicella-zoster virus, herpes simplex virus, and respiratory pathogens such as parainfluenza virus, respiratory syncytial virus, or influenza viruses. Also very rare: Toxoplasma, Mycobacteria, Chlamydia, Bartonella, and Legionella. And in 25%, fever is undefined. So, for example, in patients with drug fever or toxic effects of chemotherapy or like an anti-tumor response or undefined pathogens. And the last group of fever of unknown origin, the last category, is HIV-related fever. I told you that this fever is associated with mycobacterial diseases, pneumocytosis, cytomegalovirus, histoplasmosis, lymphoma, and drug fever. Of course, you should every time get a full anamnesis of every patient with fever of unknown origin, and you should put several questions, and you should receive the answers on these questions. So you should verify fevers and establish pattern, and questions: localizing symptoms, workplace, having pets, recent travel, history of connective tissue disease, history of cancer or immunosuppression, taking of medications, drug use, or familial fever syndromes. Physical examination is extremely important for every patient with fever of unknown origin. Of course, you should remember about palpation, for example, palpation of temporal artery, and of course, tenderness of this artery, of temporal artery. It's very typical for old patients with Harton syndrome or temporal arteriitis, systemic vasculitis. Of course, you should exclude sinusitis and check sinus tenderness. Auscultation is very important. You should auscultate the heart every time if you suspect myocarditis, pericarditis, infectious endocarditis, even tumors of the heart, such as myxoma of left atrium. Very often, very often etiology factor of fever of unknown origin is a tumor of left atrium, such as myxoma. Of course, you should check presence of osseous nodes, genuine lesions, conjunctival hemorrhage for infectious endocarditis. Palpation of lymph nodes in patients with hemoblastosis, tuberculosis, infectious diseases. Palpation of thyroid gland. Of course, you should check rectum to exclude perirectal abscesses, especially in patients with neutropenia and, of course, cancer of rectum. Abdominal palpation to exclude presence of splenomegaly or hepatomegaly. Deep vein thrombosis is a very common reason of pulmonary embolism, and of course you should exclude this disease in patients with syndrome of fever of unknown origin. Examination of skin, mucous membranes, teeth is also very important. So, evaluation of fever of unknown origin. The following laboratory studies are the most usual. Of course, for every patient you should prescribe some investigations, such as complete blood count, serum chemistries, liver function tests, urine analysis, blood cultures, HIV antibody, and chest X-ray. And sometimes serological investigations and even bone marrow biopsy. On this picture, on the slide, you can find a thrombus, a venous clot in patient with deep vein thrombosis. Of course, it's a risk factor for pulmonary embolism. Patient with lung cancer. So, evaluation of fever of unknown origin. For every patient with fever during more than 3 weeks, you should suspect fever of unknown origin, and every time you should stop with any medications. So you should discontinue all non-essential medications. And in case of drug fever, fever will resolve in less than 72 hours. Persistence of fever more than 72 hours after discontinuation of medications exclude drug fever like an etiological factor. So you should prescribe abdominal CT or technetium-based nuclear scan. Of course, you want to identify focus, maybe in abdominal cavity, to find a reason, etiology, the main disease which may lead to formation of fever of unknown origin. Of course, you should exclude infective endocarditis, and you should use due criteria to rule in or rule out infectious endocarditis. And of course, you should prescribe Doppler imaging of lower extremities, and in case of positive Doppler imaging, so if you could find a blood clot, a thrombus in the deep vein, you can prescribe low molecular weight heparins for every patient. In old patients after 50 years old, in case of tenderness of temporal artery, of course you should prescribe temporal artery biopsy. Sometimes you could prescribe liver biopsy or another internal organs biopsy. But sometimes we could say that the patient has undiagnosed fever of unknown origin, and of course in this case you should follow him clinically. Management of fever of unknown origin. You should withhold therapy until the cause is found. But there are few exceptions, like neutropenic fever. Of course, you should prescribe corticosteroids if you suspect temporal arteritis. And of course, you may prescribe antipyretics and even antibiotics for unstable hospitalized patients. A review of the literature showed a mortality rate of 12 to 35% for classic fever of unknown origin. And we can find higher mortality if malignancy is identified, and low mortality if infection is identified. If no cause is identified, 50 to 100%, in this case serious, have a spontaneous recovery. So, summary. The definition of classic fever of unknown origin is temperature higher than 101 degrees Fahrenheit for more than 3 weeks and no diagnosis after 3 days in the hospital or 3 clinic visits. Definition differs for patients with neutropenia, HIV, or suspected nosocomial onset. Causes of fever of unknown origin are diverse, but can be categorized into infectious, malignancy, connective tissue disease, and miscellaneous causes. Comprehensive history and physical exam are an important first step in fever of unknown origin evaluation. Evaluation of fever of unknown origin with laboratory test and imaging should be directed towards the most likely causes based on the history and physical. The key to management of fever is to withhold specific treatment, but it's necessary to note exceptions until the cause is found. Thank you for your attention. Take care and goodbye.